Thank you everyone for joining us for the first geriatric medicine seminar for 2024. My name is Dr. Emily Gordon. I'm a geriatrician at the PA Hospital and a senior lecturer with the Aging Research Group at UQ. Today's topic I'm really excited to present because I think certainly in the clinical space this is something that we are increasingly facing and needing to develop our skills in. We have two amazing presenters today. I'd like you all to welcome, first of all, Associate Professor Ajay Macharouthu. Ajay currently works as a staff specialist in consultation liaison psychiatry for older persons. He's the ECT Director and Director of Training in Psychiatry for Cairns and Hinterland Hospital and he is an adjunct associate professor at James Cook University, Cairns, and the deputy chair of QDA, Queensland Dementia Aging Frailty Network, who, along with the Australian Frailty Network, is providing this seminar today. We're also just reminded to go on mute, please.
Now or
second speaker today is Associate Professor Anne Wand. Anne is a consultant psychiatrist, a conjoint associate professor at the University of Sydney and adjunct associate professor at the University of New South Wales. She's a senior staff specialist with older people's mental health and the medical lead for mental health research in the Sydney Local Health District. Anne is a clinician researcher whose PhD investigated self-harm and suicide in older adults. So today we're going to start the presentation with Ajay, followed by Anne, and then we'll have some time at the end to ask any questions. So please pop any questions into the chat, or you'll be more than welcome to raise your hand and ask those questions directly at the end. Thank you everyone for joining us. And Ajay, I'll hand over to you.
Thanks, Emily. Thanks for a warm introduction, and it's an absolute pleasure to be here. So can everyone see my screen? Yeah, perfect. Is that moving?
Yes.
Okay, perfect then. Okay, let me start with acknowledgements. So I acknowledge Aboriginal people and Torres Strait Islanders as this country's First Nations people. I recognize First Nation people and communities as traditional and cultural custodians of the lands on which we work to provide safe and quality health services. I pay my respects to elders past, present, and emerging. So depression in in older persons is a huge topic. So these would be our learning objectives. And also, if we have a time, probably we'll look at a case study. And also I have to acknowledge one of my colleagues here, Megan Nitz, who is a fellow old age psychiatrist from Brisbane. I have taken some of the slides from her presentation, which she does in further psychiatry training. Okay, coming to the demographics. Australia is growing older, and currently we are sitting around 15% of the whole population. Plus, in the coming decades, the plus 85 age group is going to increase. And in 2016 and 17, about 41% of the hospital beds were occupied by older people. And this was a decade ago. And if we redo that audit, probably we are sitting somewhere around 50. And in the coming decades, maybe we are not that far from the UK stats, from the document Who Cares Wins, where 2/3 of the hospital beds will be occupied by older people, and about 80% will have the 3Ds, the dementias, deliriums, and depressions. So coming to old age depression, so the current prevalence sits around between 10 to 15%, and approximately 10% experience anxiety. And the rates significantly increase in a residential aged care facilities to around 35%. And with dementia, depression rates increase by about 3 to 4 times. I feel that these stats are quite underreported, and depression is significantly underdiagnosed. So some of the reasons for underdiagnosis with regards to ageism and as well as its challenges. So there is a high probability of normalizing and minimizing depression and as well as losses as part of aging, and also downplaying the seriousness of suicide attempts, which Anne is going to talk in the next talk, and saying that they are understandable. And importantly, there is a huge exclusion or a lack of specialized psychiatry of old age services and clinicians, which I was talking to Emily at the beginning of this talk, and clinicians with experience with older people. And I'm a CL psychiatrist for older persons, and probably I'm the only guy who provides that service in Queensland. And also there is a huge exclusion of older people with regards to representation in service planning and lived experience, and lacking a voice, which again adds on to these issues. Okay, let's look at this ICD-10 classification of depression. So this is for all age groups. So you need to have a pervasive lowering of mood for at least 2 weeks, and with other core features of lack of energy and loss of interest, and which also we call it as anhedonia, with associated symptoms of insomnia, lack of appetite and weight loss, suicidal thoughts, agitation or slowing of movements, guilt, low self-confidence, and poor concentration, and indecisiveness as some of the cognitive symptoms they present with. So overall, these 10 symptoms define the degree of depression, and also would address some of the management. So we divide subclassify depression into mild, moderate, and severe. The mild and moderate normally would be dealt with psychological therapies, and the severe depression requiring antidepressants and as well as psychological therapies. There is further subdivision of severe depression into psychotic symptoms and non-psychotic symptoms, which are mood congruent or mood incongruent. And there are a number of types of depression: unipolar depression, bipolar depression, dysthymia, and adjustment disorder. And I would be concentrating on unipolar depression today. Okay, coming to the depression in older people. So they often present differently. So the DSM-5 or DSM-4 or the ICD-10 criteria are not that helpful because of the underreporting of the depressive symptoms, especially with regards to not acknowledging low mood. We may call them as the smiling depressive patients. The common symptoms they present with would be the loss of interest with significant social and emotional isolation, and as well as new onset of alcohol use and overuse of benzos. And the other common symptoms are the lack of enjoyment and the new onset apprehension, anxiety, and agitation, and as well as significant insomnia and persistent thoughts of death and negative ruminations. And the presentation would be in the form of critical somatic symptoms in the form of pain and physical symptoms, preoccupations with regards to bowel and bladder, and as well as frequent medical admissions. They also present with cognitive issues in the form of poor concentration, which indirectly affects the short-term memory and immediate memories. And we call them as pseudodementias. And appetite and weight changes, and also new onset anxiety. But all these things, you would see that in dementia patients, and as well as in it becomes difficult to differentiate a depression. But the critical thing is with regards to the rapid deterioration of functioning, which should highlight that this is more than dementia, and probably we need to diagnose more of or screen depression in these cases. So the differential diagnosis is with regards to these 3Ds, depression, delirium, and as well as dementias. So for a new diagnosis of dementia, you can't make a new diagnosis unless you exclude a depression and as well as delirium. So with regards to depression, you need to have that low mood and as well as the constitutional mood symptoms and as well as depressive symptoms to support the diagnosis. But more importantly, I would be concentrating on those activities of daily living where there is a rapid deterioration over a short period of time when compared to dementias. Delirium, you would see that, but it fluctuates and it improves over a period of time. And self-awareness, there's a bit of an insight with regards to the memory impairment in depressive patients when compared to dementia and delirium patients. There are a few conundrums which sprout from these differential diagnoses. So depression versus hypoactive delirium. Sometimes it tests some of the most experienced geriatricians and as well as old age psychiatrists and CL psychiatrists. And as a CL psychiatrist myself for older people, I would like to say that 46% of the hospitalized patients referred as depression to CL psychiatry have a hypoactive delirium. And it's a fact, I'm not making this up. And just because the hypoactive delirium, you have almost mirror symptomatology with social and emotional isolation, the patient not engaging with rehab, non-complying with treatments, not eating, drinking. And it's easy for physicians to start these patients on medication, especially antidepressants, which have significant anticholinergic side effects. So, and what you see is the mortality rates in hypoactive delirium are higher when compared to hyperactive delirium, just because of sometimes the misdiagnosis or lack of diagnosis, and also to look at the factors which are causing the delirium. So it's important that we tighten up the screening around the delirium and get the diagnosis right. And the other differential diagnosis which needs to, the depression needs to be differentiated would be the grief. So the grief reaction similarly has an identifiable loss, but most importantly, they would have good days and bad days and fluctuating physical symptoms. And more importantly, the self-esteem is well preserved in these patients. And although they have passive thoughts of death and the being with their wanting to be reunited with the deceased loved ones, you don't have the active suicidal planning and ideas. So grief, we normally do not treat with antidepressants, but in case if the distress and if it gets prolonged, it does require further medication and has to be looked into as a pathological grief. So there are a number of causes for depression. So it's a biopsychosocial approach, what we need to take. So with regards to the psychosocial aspects, we are looking at social isolation and as well as loneliness, and also in the form of loss in old age, especially with death of the partner, loss of independence and loss of health. From a biological side of things, I mean, apart other than the genetic factors, we are looking at a complex relationship between physical illness, disability, and as well as depression. So it's associated, it's a comorbid illness with a number of chronic disorders, including endocrine disorders, Parkinson's, dementia, and as well as ongoing infections. But cerebrovascular disease presents with major challenges, and especially with periventricular white matter ischemic changes, which we commonly call it as vascular depression, is one of the reasons for the treatment-resistant depression and challenges with regards to the management, which we'll look into later. And also, the number of the patients are on a cocktail of medications which have an impact on one's mood. So it's important to optimize these medications too. Let's look at a case study. So I have to acknowledge Megan Nibs for this fantastic case. So we are looking at Mr. M, who is in his mid-70s, referred by a staff at nursing home. So he presented with marked agitation and refusal of cares. He has significant weight loss, more than 35 kilograms, on a background of a diagnosis of Alzheimer's dementia made a couple of years ago. He was placed in care around 12 months prior to referral from medical unit, as his wife was unable to bear the carer burden and with double incontinence. So he was noted to have had a significant history of depression, including ECT, with a period of depression in his 30s. Antidepressant medication has had a significant dose reductions. That is, he was on a tricyclic antidepressant when in medical unit, could have been reduced due to the anticholinergic side effects, but until just prior to placement. So at the time of assessment, he was withdrawn, unable to participate in interview, and scoring poorly on mini-mental state examination, and mostly due to the inability to complete tasks. There was a marked weight loss, and he was commenced on antidepressant, but the efficacy was poor. So he was admitted to the medical unit and was observed and was diagnosed with severe melancholic depressive episode, as well as he was put on a mental health act for an emergency ECT. So he received around 10 ECTs over a period of 4 weeks, and there was a significant and dramatic improvement in his mental state. He was augmented with the antidepressant was augmented with lithium to sustain the benefits of ECT. And the occupational therapy assessment stated that he was independent in his activities of daily living. So he was discharged home with wife and did not, although he never returned to the high level of care, but he remained at home and not in a nursing home setting. and required one more admission 6 years later. He restored several vintage cars with improved quality of life. Okay, so the learning points from this case, what I would like to highlight is around jumping onto a diagnosis of dementia and for a person who had a fairly rapid decline in functioning. I mean, this really poses major challenges. We need to clearly look at the decline, how quickly. We do have rapidly progressive dementias, which we need to think about. I mean, those are exceptions to the rule. But whenever you have that progression, I think we need to screen for depression more robustly. And also we need to consider the past history of depression. In this case, it was very clear that this person had a major episode of depression requiring ECT treatments. So probably he was functioning at a very severe depressive episode at that point. And also the importance of maintenance medication and the potential impact of stopping those psychiatric medications. We don't stop other medications such as for hypertension. So it's important that we continue. Palliating patients when you have unexplained weight loss and poor oral intake, probably depression needs to be considered and screened robustly again. And again, presentation that looks like confusional and behavioral disturbances could be again severe depression. So, I mean, there are a number of ways it presents with, and not necessarily that it follows a DSM-5 or an ICD-10 criteria for a diagnosis. So the keys for early detection and differentiation and diagnosing depression correctly, but also refer to the specialist psychogeriatrician in case you're in doubt. Okay, let's move on to the management. I have 5 more minutes here. The general principles of management. So for any of the psychotropics, including antidepressants or antipsychotics or mood stabilizers in elderly, we start low and go slow with the titration, and also think about the frailty. Respect the pharmacokinetics and the dynamics of the patient, and has to be a patient-centered and person-centered approach. And when you're starting an antidepressant and titrating, probably we need to treat it with an adequate dose for an adequate period. So in an elderly person, it is 6 to 8 weeks. They would take longer for the efficacy, for improved efficacy, when compared to the younger adults who takes about 4 to 6 weeks. So planning your outpatient clinics around the 4th or 6th week would be more appropriate. And the choice of the antidepressant should be a safe, tolerable, and cost-effective approach there. Medication optimizations. I mean, sometimes the cognitive reserve versus anticholinergic burden is the main issue. So the choice of the antidepressant depends on that. And usually we go with an SSRI rather than a TCA. Address polypharmacy, drug interactions, and as well as physical comorbidities. And more importantly, regular medication review and physical monitoring. And to have a biopsychosocial approach, it's just not medication. We need to look at the social aspects and as well as the psychological therapies too. The poor prognostic factors in depression are predominantly these 4. So medical illness burden is one of the greatest risk factor, where we struggle with treatment-resistant depression. And also new onset comorbid anxiety. These are very, very complex patients with agitated depression, which makes it even more difficult because they're quite sensitive to the antidepressant serotonergic effects. And cognitive impairment, especially with executive dysfunction and the white matter hyperintensities, which we call it as vascular depression, you would have those management challenges with antidepressant agents. Okay, so management of depression, again, I would like to take a biopsychosocial approach, and the best evidence is for a combination of both psychological and pharmacological therapies. When you're looking at medication side of things, though, there is various psychotropic medications which come into play here. So antidepressants, mood stabilizers, lithium, antipsychotics, and also I'll finish off with the neurostimulation as we go along. And social side of things, it's important that we address the loneliness and social isolation. And I mean, simple tasks like befriending services and having the home care package, aged care package, looking at taking them for outings and exercise and even for shopping are quite beneficial. And coming to psychological therapies, so there is a fantastic meta-analysis from 2013, which stated that psychological therapies work in old age depression. But Specifically, they mentioned that the CBT, which is cognitive behavioral therapy, the IPT, which is interpersonal therapy, and PST, which is problem solving therapy. So these are the three which stood out and were statistically significant once bias was taken into consideration in this study. The problem with psychological therapies is lack of resources, especially the underfunded psychological services within hospitals, and as well as in private, they have huge waiting lists. So coming to the antidepressants, as I said, SSRIs are first line. So use antidepressants which have worked previously, but initiation SSRIs, again, you have a number of issues. They cause hyponatremia, QTC prolongations, postal hypos, the GI issues, and they inhibit liver enzymes, especially the SSRIs, and some of them have anticholinergic side effects. Citalopram, I have to stress here, so the maximum dose of citalopram in elderly, according to the SPC from the Electronic Medicines Compendium, is around 10 milligrams for citalopram, and citalopram is 20 milligrams. And importantly, the SPC says that citalopram cannot be combined with other QTC prolonging agents. Sertraline is relatively safe. Paroxetine is a brilliant antidepressant, but unfortunately has anticholinergic and withdrawal and issues. And fluoxetine has a long T-half, so it's not my preferred first line treatment. Other antidepressants, SNRIs, so venlafaxine, duloxetine, desvenlafaxine are my go-to if the SSRIs do not work. And then you have the mirtazapine, agomelatine, and otioxetine are unfortunately IPAs, so not available in a hospital setting. If patient can afford, that's great. MAOIs have their own limitations, especially with the diet. And TCAs is the anticholinergic side effects. These are gold standards, but unfortunately, the anticholinergic side effects makes it difficult to utilize. So I would like to highlight this meta-analysis, which clearly states that the antidepressants do work, but the ones which are highlighted in yellow clearly show that the best in head-to-head studies. So, and the choice here depends on the side effect profile. So you would go with escitalopram or citalopram to start with, and then look at otioxetine, agomelatine, or venlafaxine. So this is the table I normally use when I initiate and titrate the medication to look at the metabolic parameters, the ECG, and the blood counts, etc. So I think this presentation would be shared with you all. So you could just follow this, and this is prepared by one of the community colleagues in Cairns here. So let's look at the treatment-resistant depression strategies. What do I mean by treatment-resistant depression? So you're looking at a poor efficacy with 2 or more classes of antidepressants used for adequate period and dosage. So the strategies, when you're looking at the treatment-resistant depression, you're almost referring this patient to your specialist colleagues, especially the psychogeriatricians. So the augmentation strategies I would be looking at is antidepressant augmentation. If the SSRIs haven't worked, I would move to an SNRI such as a venlafaxine. And even if the efficacy is poor, then I will add a mirtazapine on top of that. And if it doesn't work, probably the other options I have is antipsychotic augmentation of the current antidepressant with either quetiapine or aripiprazole. And some more options in the form of lithium. Lithium is just not used in bipolar. Sometimes it's a very effective agent in unipolar depression, especially treatment-resistant unipolar depression. And some of the other anticonvulsants, such as lamotrigine, so also helps. The triiodothyronine, and more importantly, psychotherapy is a brilliant augmenter of your antidepressant. So coming to treatment-resistant depression, yeah, it works. The mean response with antidepressants is around 52, that is 1 in 2 will improve with treatment-resistant depression. And the best response is for sequential treatment programs, which combine both psychological and pharmacological treatments. A curious case of lithium here. So many patients on long-term lithium, please do not stop it. So they do cause renal issues and thyroid issues. Even with acute advanced kidney disease, lithium can be well maintained with integrated approach with nephrologists. My preference is to go with a 0.4 of the therapeutic index levels, which is the least effective level, and which would really help in keeping these patients well. Because when someone relapses, if you stop the lithium, is absolutely challenging to treat these patients. TCAs, because of the anticholinergic side effects, sometimes you may have to address these and switch. But again, if you can continue these medications, please do so. So coming to the neurostimulation, so ECT does work, and then it works even better in older people when compared to younger persons with regards to remission and response rates. And more importantly, it's significantly better than your antidepressant medications. And the other stimulation therapies which have been highlighted and getting more popular lately are the RTMS, or the transmagnetic stimulation. So the other, which is growing, is semi-invasive, or in fact non-invasive when compared to ECT. But if you look at this stat, I think neurostimulation has its own presence to help, especially with your patients who have significant side effects. You may be looking at TMS as an alternative. ECT is a very well scrutinized treatment, and it's reserved only for the most severe patients and agitated depressions. So TMS could be your alternative in this regard. So a few take-home messages for you. So you have to really reinvent the wheel, especially with depression. So it doesn't go through the normal criteria by the ICD-10 or by DSM-5, and it's different from that perspective. Always think about it as a diagnostic possibility. Any new onset anxiety is a huge red flag and is almost always depression in elderly. Does the timeline make sense? Yes, pseudodementia or severe depression deteriorates quick when compared to neurocognitive disorder. Suicidal ideation in older people is not understandable, and that probably needs to be signposted, and you need to bring in the psychogeriatrician and the mental health services into play. Older males are the highest group of completed suicide, probably needs to be addressed. Talk the case over with your friendly old age psychiatry team. We are always there to help you. And the integrated and collaborative approach is the way forward. I will leave you with a date for your diary. So the next Delirium conference by the Australasian Delirium Association is in Cairns next year in July. So you're all invited. Thank you. Over to you, Anne.
Emily, you're on mute. Sorry.
Emily, you're in. Yeah. Perfect.
Sorry, Ajay, I was just thanking you for your whirlwind tour, because that's very difficult to summarize such a huge topic in such a short period of time. So we appreciate it. And over to you, Anne.
Thanks very much. But this is going to complement Ajay's talk quite well. So I'm talking about the pointy end that sometimes comes from depressive illnesses in older adults. And this is a very practical kind of guide for what to do, what to look for, who to call in. So to start off with, Ajay mentioned that men over 85 have the highest rate of suicide, and that's out of all the age groups. There's a close relationship between self-harm and suicide in older adults. They share common risk factors. There's high lethality of self-harm in late life compared to younger adults. So for example, for every 4 self-harm incidents in an older person, there's 1 death by suicide. Whereas in a younger adult, it's 300 to 1. So any self-harm in an older person is a huge red flag to be taken seriously. And there's higher lethality of self-harm in older adults. We know a lot about epidemiological risk factors for self-harm in older people, but they're often not very helpful in helping us work out who needs attention, because they're common in older people in general, most of whom don't die by suicide and who don't self-harm. So I guess the bottom line here is that any self-harm occurring in an older person is a red flag. Always keep that ratio in mind, 4 to 1 versus 300 to 1. someone's presenting with self-harm, it needs to be thoroughly assessed and certainly taken seriously. So the people that you're going to be seeing in clinics and in hospital are going to have physical illnesses. Population-based cohort studies of people aged 50 or more admitted to hospital for self-harm and non-self-harm injuries. Those who self-harmed had a higher ratio of mental health conditions, neurological problems, diabetes, chronic respiratory disease, liver disease, tinnitus and pain. So pretty common presentations. So again, keep this on your radar when you're seeing people with those conditions. People with dementia are at higher risk of poisoning compared to people without dementia, and that's for both intentional and non-intentional self-poisoning. So don't dismiss a person with dementia as not being at risk of suicide. That's not the case. And people living with dementia who also self-harm have a greater one-year mortality, higher readmission rates, and longer lengths of stay. So again, who are we thinking about to be concerned about? So certainly someone who's got dementia and self-harms is at high risk of bad outcomes and certainly for a target for intervention. In another study that we've recently published and one which is under review, so this is a cohort study, enormous data linkage study of New South Wales hospital data. So we had 155,000 people living with dementia, 29,000 people who had self-harmed. And we followed up a cohort, everyone who presented to hospitals from the age of 40 over a 13-year period. So we found that most self-harm occurs in people with dementia within that first 2 years of diagnosis. Men who have dementia and mental health comorbidity are more likely to self-harm. Men who self-harmed had the greatest risk of going on to develop a dementia diagnosis in that follow-up period. And so we did wonder whether self-harm could indicate an undiagnosed or a prodromal dementia for some. And mortality increases when people who self-harm then develop dementia. A really interesting finding was that those people who went on to have outpatient mental health days, so ambulatory care, had a reduction in all-cause mortality. So suicide was a tiny proportion of this group. There were only 450 suicide deaths, so 2%, but all-cause mortality was reduced by referring to older persons and general mental health services. So from this series of studies, we concluded that men and people with mental health comorbidity and dementia may particularly benefit from post-diagnostic mental and behavioural support to reduce risk. There's certainly implications in the aged care setting, that if you're identifying, making a dementia diagnosis, particularly in early dementia, to being attuned to thinking about what is the impact on this person, how are they responding to that diagnosis, are there mental health and behavioural issues which might necessitate referral onto mental health and social services as relevant. So it's important to think about risk factors, even though yes, they can be common in older people in general. It can help you sort of tune your focus on who needs more support or who to be worried about. And it also helps guide what you're going to do about it. So if you pick up suicidality, self-harm, how are you going to address that in your management plan? So there are potentially modifiable factors. So those you can screen for, identify, and potentially do something about. Things like a depressive illness, another mental illness, alcohol misuse, cognitive impairment, early cognitive decline, loneliness, limited social support. Physical illness, particularly when it's associated with disability, is a very important risk factor. And the impact of life events, recognising that and doing something to address it. There's static risk factors. So these are things that we can't change, but they're important to ask about because, again, they help us tune our risk assessment. So things like previous self-harm or suicide attempts, childhood adversity. So even things that might have happened when the person was in their early childhood can have impact in the 80s and 90s. A history of limited coping skills and adversity. Similarly, it's important to think about resilience factors. These are the things you're going to call upon in your management plan to help get the person through this period of crisis. So for some people, that'll be perseverance, determination to move forward, self-efficacy, strategies they've used to successfully recover from previous adversity, spirituality, social support and families, And a particularly important one is having a purpose and meaning in life. We've all seen people who, once they've retired, have completely dropped their bundle, lost that sense of purpose and meaning, and will to live. So these risk factors have informed one of the models of safety planning for older adults, which calls upon the 5 Ds of suicide in late life. So that's depression, disability, disconnectedness, disease, i.e. physical illness, and deadly means. And if you remember nothing else, that is a good guide for 5 key things to look for and think about when you're seeing an older adult with self-harm and suicide risk. So some years ago, we did a longitudinal study looking at self-harm in late life. So we were very interested in older adults, the oldest old, so those over 80, and why they self-harmed. We wanted to explore this from the perspective of the older person themselves, their carer, and their GP, and then look at what happened 1 year later, their reflections on the self-harm and the clinical outcomes. And then to use this data for educational interventions to change knowledge and attitudes and look at improving service delivery. And our education was focused on 2 groups. It was aged care services, mental health services, and then Lifeline, so the crisis support. So we included people aged 80 or more who had self-harmed in the last month. They came from teaching hospitals and community mental health services, so all public system. They each had a structured psychiatric assessment and cognitive testing with an old age psychiatrist. And they had an in-depth interview which focused on the self-harm, looking at a process called narrative inquiry, open-ended questions to help the participant form a narrative of their reflections on the self-harm and their perceptions of care. These were audio recorded and transcribed. Their carer, their nominated carer or family member, was also interviewed separately, specifically focusing on the self-harm. GPs were sent questionnaires, again, focused on the older person's self-harm. And we used qualitative analysis, so grounded theory, to guide our thematic analysis and we recruited people until we didn't get any new themes coming up in our data analysis. So here are some quotes reflecting the first theme for older people who self-harmed. So we had 30 older adults that took part. They were aged between 80 and 102. Half were women. Just under half didn't speak English, so interpreters were used. And 43% had a major depressive illness. Almost everybody had cognitive impairment, not surprising given the age of the cohort. 47% had dementia and 43% had MCI. Importantly, 20% of the group didn't have any mental illness, no diagnosis. So there were myriad reasons why older people self-harmed, 2/3 of whom self-harmed with suicidal intent. So physical symptoms, unremitting, unpleasant symptoms, mental illness, social circumstances, relational factors in the person's clinical and familial networks. Emergent themes were enough is enough, loneliness and not belonging, feeling like a burden, helplessness with rejection, and untenable situations, so things like elder abuse. Feeling invalidated when raising issues was an important theme, and perceived rejection or non-responsiveness from both clinicians and family. Carer interviews revealed these themes, largely echoing that of the older person, identifying the difficulties that the older person had articulating their distress and seeking help, as well as other issues around communication. So their themes included they can't communicate, suicide secrets, the importance of invalidation, guilt and self-blame. The carers also spoke about the burden and emotional consequence of their relative self-harm on them as a person. GPs, the themes from their surveys were helplessness, therapeutic nihilism, and professional isolation. So 1 year later, we looked at those same 3 cohorts. We got almost every carer. Quite a few of the older people had died, none by suicide. 5 of the older people had repeated self-harm, 8 still wanted to die. We've had many more converting to dementia now. Much fewer had depression. And we've gone from a doubling of those living at home to now living in residential aged care. So we followed up these three groups and triangulated the themes emerging from their interviews. For the older person, themes included denial and secrets, endless suffering, more invalidation, with the flip side for some people feeling that actually the self-harm led to them feeling heard, and being miserable in care. For carers, similarly, they identified denial and secrets, a persistent wish to die in their relative, perceived abandonment by clinicians, and an unending ongoing burden for the carers. Patients and carers described many of the contributing factors to the original self-harm persisting at 1 year follow-up, whereas GPs, by contrast, felt the patient's problems were understandable, had resolved, and they understood what was going on. Everything was sorted. They felt confident in care provision and risk reduction, which was quite at odds with the negative appraisals by patients and carers of invalidation, ageism, poor communication, and therapeutic nihilism. It was clear that moving into residential aged care was a significant distressing event for many, often perceived as further rejection and invalidation, which echoed the original reasons for self-harm. Many of the older adults didn't receive specialist follow-up, so perhaps mental health services were considering moving into care as job done and pulling out of patient care because there was a perception of supervision or surveillance that was going on. And this lack of specialist follow-up, helps explain what was going on for the GPs who felt professionally isolated and that sense of therapeutic nihilism. It's a complicated group to look after. So we use this data from the qualitative studies combined with the quantitative literature looking at risk factors and epidemiology to come up with a practical guide to assist GPs in managing and identifying self-harm. So one of the key messages is that not all self-harm is about suicide. You need to ask and explore what it's about. Secondly, seems straightforward, but we often don't do it, is seeing people on their own. It's extremely hard for somebody to talk about their suicidal thoughts in front of their wife of 30, 50 years. Be embarrassing. Often you'll be in situations where the carer will shut down that line of conversation, or even sometimes when I've had interpreters shut down that line of conversation because they're uncomfortable about it. If someone does disclose self-harm or suicidal thoughts or actions, you need to explore them. You can't make them worse, by asking about it. You're not going to put the thought in their mind. And often people will be quite relieved that somebody's asked them, that they're not freaking out and they're listening to them. So exploring when the thoughts arose, how often are they there? What have they thought about doing? Have they taken any steps towards doing something? Do they have access to means? And you can be quite blunt about that. Okay, you've thought about an overdose. Do you have tablets at home? Have you collected anything? Have they made arrangements in anticipation for their death? Have they had self-harm or suicide attempts in the past? And important to explore both their healthy and unhealthy coping strategies. So you've been feeling like this. What have you done, to try and, reduce those thoughts? And you might get someone who's been popping a heap of benzos, their little jar of alprazolam that's in the bedside drawer, or drinking more alcohol, or others who might be using healthy coping strategies that you can call upon, maybe more exercise, or they ring a friend. You want to acknowledge their distress. Identify those areas of suffering. So if you think back to that table about risk factors, what are the physical things going on, the psychological things, social, spiritual, and exploring the impact of their symptoms on their quality of life, mood, and function. So basically you understand what's driving these feelings. Want to screen for comorbidity, depression, substance misuse. These are things you can do something about that are potentially reversible. You want to convey realistic optimism that something can be done to help with these underlying factors. Definitely think about the needs of new nursing home residents. Placement is a major life event associated with often negative connotations and psychosocial losses. It's not a set and forget answer for our people who've self-harmed. They are often needing more support. ageism, which Ajay also spoke about, is so important. There are so many studies showing that even us working in aged care, an older person's mental health have a perception that it's normal to be old and depressed, or it's normal to think about wanting to die, that it's understandable. You can see that if that's your framework, there's no way you're going to have any intervention. Dismissing self-harm as attention-seeking or not serious. Underestimating the impact of risk factors. So, for example, a recent suicide investigation I was involved in was a man who was drinking, who'd never drunk alcohol in his life, who died by suicide. These things are important. It doesn't matter if it's 2 glasses of wine a day. You know, for an older person and someone who's never drunk before, that's significant. So in terms of management, so there's the acute risk. Firstly, thinking about the setting of care. Can they stay home? Have they got supports at home? Are they engaging with you? What level of acuity are their thoughts and actions? Do they have the means to self-harm? Is it fixable? Or are there things you can do to ameliorate risk and improve safety at home? Are those thoughts ongoing? Are they engaging with you or shutting you down and shutting you out? That's someone to be very worried about. Involve carers. So often we're really careful around this and thinking, well, if somebody's told me something, I can't tell their wife or I can't tell their daughter. But we clinicians are a blip in these persons' lives. The people who live with them are best placed to help and be allies in our management plans. You want to encourage the older person to involve their carers and to allow you to talk to their carers about what's going on. But if they decline, you really need to think seriously about whether this is a situation that you might need to override confidentiality for safety reasons. In terms of subacute risk and how you're going to manage that, you really want to look at those underlying factors that you've identified in this particular person in front of you. They're different for all older people, and see what are some specific actions to address them. So someone with unremitting nausea, addressing the nausea, or chronic pain, looking at different strategies which maybe haven't been put in place. If there's a depressive illness, sorting that out. Addressing substance misuse or loneliness, so matching to needs. If there's functional disability and struggling to maintain ADLs at home, then looking at services to help with that. For people who feel like they've lost control, which often happens as people get older and they have new symptoms, distressing symptoms, sometimes something like an advanced care plan can be really containing, that the person can put forward their wishes and feel confident that they'll be heard. Again, don't forget the carers. They're allies and they're going to help you with management, but they also may need support in their own right, because that event of self-harm or suicide attempt in their relative can be extremely distressing. And then you want to follow up. So we did some work from the Ministry of Health a couple of years ago for New South Wales Ministry of Health, looking at a recommended plan for when older person presents with self-harm, wherever they are, whether they're in primary care, emergency department, nursing home, etc., or an aged care setting, your clinics. Sorting out the immediate risk, which is often with an acute care team or an ED, but having a prompt referral, moving them on to older person's mental health, where we know what you get. Assertive follow-up, case management, psychogeriatrician, MDT meetings, co-design safety plan. It's not surprising to me that those people with dementia and self-harm who made it to community mental health did better and lived longer, because there is a very holistic approach that's taken, certainly in our country. And then a warm handover. So when you're getting to that point where people are either going ED to home or mental health unit to home or back to a nursing home, that there's a direct discussion with the next person who's taking over care, whether that's the mental health service or the GP. Some further work that we did more recently was looking at suicide prevention pathways for older people. And again, similar principles came up. So continuity of care, keeping the same clinician involved over follow-up period. Specific education and training, not just for healthcare professionals at the different settings where older people are going to be, but for gatekeepers, community leaders, spiritual leaders, pharmacists who might be filling scripts for older people who are presenting, things to look out for and how to refer on. clear communication, and again, that transfer of care, being very explicit and direct in how that happens. So in summary, you want to listen and validate older adult concerns, and they are specific to that person, so you need to listen. You want to explore self-harm and suicidal ideation in detail and speak openly about it, including factors which might lead to disinhibition or increased risk, so impulsivity. Things like alcohol, benzos, opioids that might be around the house. Involve families and carers. And then the crux of your plan is, what are those modifiable factors that are contributing to this self-harm and suicidal ideation, and doing something to address them. And finally, referring early to older person's mental health. We're lucky that we do have that service available here. Thank you.
Thank you, Anne. Thank you so much. That was a really practical guide, and I certainly feel a little bit more confident moving a bit forward when that bomb is dropped in outpatient clinic, and I don't quite know what to do with it. So we have one question. Please, I would encourage anyone to pop up your hand or pop a question into the chat. There's one question in there at the moment. Perhaps this might be directed at you, Anne, but Ajay, I'm sure you might have a view as well. So you can see it there. How might more accommodating voluntary assisted death laws for people living with dementia alter these figures or have an impact on suicide management plans?
Oh, that's a can of worms, and very early in the piece of discussion to go straight to VAD. Yeah, so we don't know, actually. So it could be that it acts like advanced care plans do for some people, that knowing simply that you've got control can be relieving for people. And we certainly know there's a literature that there are many people who apply for VAD who never use it, but it just, the fact that they've got that facility for some point down the track, it is such a minefield for people with dementia, because often people anticipate dementia will be the worst possible thing that could happen to them, but then when they do develop it, and that may not be the case anymore. So the issue of consent and capacity to make that decision is very complicated. So I think probably I won't go into it any more than that, but I think we're going to see much more advocacy around that, because there are a lot of very loud people talking about dementia and VAD. But I would be very careful that we don't use VAD as a pathway to promoting ageism, that it's your quality of life or being an older person is not as valued as a younger person. It's simply being old or tired of life, as is a reason to request VAD in the Netherlands, is good enough to request voluntary assisted dying.
Ajay, did you have any additional comments, or happy to move on?
That's well summarized.
Benignus.
Thanks both for a great talk. It was really good to hear it. This may not be a possible question to answer, but Ajay in particular, I know with your approach to treatment of depression, the role for psychology review, which makes a lot of sense. Sometimes when we're in geriatrics, we see obviously a lot of people with varying degrees of cognitive impairment. And sometimes I'm just not sure, like, if a person sitting in front of me has enough, cognitive wherewithal to benefit from seeing a psychologist. And I know it's hard to comment because everyone's a bit different and we tailor it. And if in doubt, I tend to refer on because I guess in many respects, it's low risk intervention, right, to try and fail. But I just wondered if you could give some thoughts on how you think about that in approaching someone with a degree of cognitive impairment. And we know dementia can be quite broad, early to advanced, and how you see the role of referring to psychology in that particular setting.
Yeah, great question there, Benignus. And basically, there was this SAD AD study and the DIADS-2 study where depression and dementia, they look clearly on it. As one of the most challenging aspects is treating depression with dementia, and sertraline and mirtazapine miserably failed. And they also looked at the psychological therapies. In fact, they're ineffective when someone has cognitive impairment. But there is a therapy called as the cognitive stimulation therapy, CST. But the problem here is the improvements are not long lasting. So you need to have a mechanism where you have that sustained cognitive stimulation side of things to really make a difference to your patients. So it's a very, very challenging task.
I think the other point I'd add there is that a skilled psychologist will match the therapy to the person's ability. So they will deliver it in a way that perhaps if they haven't got the cognitive skills, they might focus on behavioural approaches, which can be very powerful, particularly in people with dementia, where the evidence is not for drugs, it's for behavioural approaches. So I think that's the other thing. So it's often good if you know what you've got in mind, what might be helpful to kind of coach, what you would like, what kind of therapy you would like the person to have.
I think BPSD's management, which Anne is trying to highlight there, you need to have a psychologist as part of your MDT to really reduce the use of antipsychotics. So the ABC, antecedents behavior and management side of things, the behavioral therapy really is the way forward.
There's a question here from Stella, which it was crossed my mind as well, because this happens in clinical practice. And I look after patients with quite advanced dementia with severe BPSD. In those patients, it can be quite common for them to vocalize what seems somewhat kind of, what's the word? Can't think of it, but Stella's given the example, they don't want to do something, whether it's attend to hygiene cares or this, that, and the other. And so they might express, I just want to kill myself, or it seems quite a off the cuff comment as a way to express frustration or fear or whatever it might be. How do you assess that kind of risk? How does the self-harm suicide risk sort of evolve over the course of the progression of the dementia and the severity of the dementia?
Yeah, so this is, I guess an example where the self-harm might not be about a mood disorder or wish to die, but actually trying to tell you, I don't like this, or I'm not having my needs met in the way in which I'd like them met, or you're not listening to me. And so I think trying to unpack where's it coming from. So it's the same principle. You still need to do, the screening questions about, where this thought has gone, how often it's there, whether it's progressed, what actions are they thinking about taking. And often in this sort of scenario, it'll be shut down pretty quickly. No, I'm not going to do that, but you're really giving me the shits, so or whatever it is. So again, focus a brief assessment of the suicide alley itself, and then looking at what's actually the music behind the phrase. And can there be a different approach to the particular situation? And look, there's so many possibilities for why somebody might say that. You're going to have to understand, what is it about the task they're being asked that they don't like? Are they afraid of something? Is it, that confusion about not really making sense of what's happening, or why somebody's wanting something to happen or doing something in a particular way? And it's helpful to bring in relatives as well, who can give you that longitudinal story about, well, this is what mum's like, and of course this happened to her many years ago, and so when you go and do that, this is what she's thinking. So yeah, that holistic assessment, which you would do for someone with dementia and BPSD.
1 o'clock now, but there's one more question here, if you'd be happy to take that, Ajay and Anne. It says, what's your experience in treating a patient who developed depression after a diagnosis of dementia without a prior history of depression? The evidence suggests that antidepressants may not be as effective for this group of patients.
Yeah, thanks for that. And yes, as I said, it's quite challenging to manage dementia, but as Anne clearly mentioned, it's the management of distress, which is very, very important. And probably the lack of evidence doesn't stop me from starting an antidepressant if there is a requirement. And the choice of the antidepressant and the continuation and the dosage depends on the side effect profile, how much the person is able to tolerate the medication side of things. And probably there's one more question there around by Rashid. So if we were to use 2 antidepressants together, so it's again SSRIs you start with, and then if sertraline or citalopram doesn't work, you move to another SSRI within the same group. You would and wait for 6 to 8 weeks for the efficacy. If it doesn't, then you go to the SNRI, which is a different class. And then if a SNRI like venlafaxine doesn't work, then the combinations I'm looking at is augmentation strategies. So the 2 antidepressants would be SNRI, that is venlafaxine plus mirtazapine. So I would augment the venlafaxine with mirtazapine 15 milligrams, or citalopram or escitalopram with mirtazapine. But again, that opens up a number of issues around hyponatremia, postural hypotension, and QTC prolongations. You need to be a bit wary. So all these things have to be, as long as the table I have displayed there, you'll be able to follow up.
And making sure people have made a concerted effort in terms of the behavioural and psychological approaches, because they have far more evidence than drugs in people with dementia, as is pointed out by the question.
Well, since it's 1:03, I wish we had another hour to talk, but I'm sure that everyone's taken away some really important messages today. So again, I'd really like to thank you, Ajay and Anne, for taking the time, putting together excellent presentations. If you're both happy to share those presentations, or for at least people to reach out to you to gain any extra details, that would be amazing. But thank you for your time, and thank you for everyone joining.